So the challenges of uterine fibroid and adenomyosis in fertility are management. Can I have the second one? How can I?
You can use the small arrow at the bottom to advance there.
The fibroid-related infertility as following. First, it will increase the uterine contractility and also impair the blood supply in the endometrium and the myomectomy. And also, this fibroid will cause uterine cavity distortion and a thicker capsule. And also, they can impair the endometrial receptibility and the gene expression. And finally, the hormone of paracrine changes such as cytokine also increase. According to the figure, leiomyoma subclassification, you can see from 0 to 8. So that means some are some mucous myoma, intramural, and 2 subserosa. And the degree, it depends on how much involved the intramural. So there's 1 and 2, the difference. And there are some systemic review of the uterine fibroid for all locations of the uterine fibroid. No doubt that will decrease. You can see the relative risk is much less in the clinical pregnancy rate, implantation rate, and ongoing live birth rate. So all are compromised in patients with all location myoma. And at the same time, you see the spontaneous miscarriage rate also increase. However, when the myoma is located in the submucous area, you even see the worsen in patient in respect to the pregnancy, implantation, and ongoing pregnancy rate. So the relative risk are even higher in those patients. So how the strategy to management this uterine fibroid? I think we can use different approaches such as uterine artery embolization or through vagina or through catheterization. Or we can use hysterectomy by laparoscopic approaches or hysteroscopic approaches. Or we can use MR guide focus uterine surgery or HIFU forever. And for the intramural myoma, type 3, 4, 5, and 6, if the size is less than 3 centimeters in diameter, we can wait, so such as expectant management. If the size of uterine fibroid is greater than 3 centimeters in diameter, we can use the medical treatment up to 3 to 6 months. This is to try to decrease the myoma size and induce migration of the myoma as far as possible away from endometrium. So you can, so if the size diminishes, we can do the natural conception or IVF. However, if no reduction, then the surgery is recommended. Then we look at our hospital in a couple of years. We collect about 224 patients doing the hysterofibroscope. You can see about 132 patients, which is 58% with abnormal uterine cavity, with some abnormal pathology, okay? So, and then we further analyze these 132 patients, and then they, some are polyps, uterine synechia, septal uterus, but about around 9% are due to some mucus, some mucosa myoma. However, after treatment, you can achieve about 33% pregnancy rate. Then I will show one case. This is some mucosa myoma type 1. That means majority is location in the uterine cavity, 35 years old, secondary infertility, and with some mucosa myoma. So you can see here the size, okay, the size of uterine submucosa myoma around 2 centimeters. So you can see the big submucosal myoma. So we can use the hysteroscope to remove this submucosal myoma. And then 2 months after, 1 month after second look, you can see still there's some residual intramural during the second look laparoscopic examination. So again, I remove this one at this, 1 month later, and then after the third look, almost gone, you see, and the submucosal myoma turned out to be intramural, so almost clean the uterine cavity. Again, about 3 months later, the patient received the intrauterine insemination with chromate and gonadotropin dual trigger, and finally by IUI or AIH, she had a baby. No need for IVF. The other case is multiple submucosal myoma. You can see here. So still two-stage approaches. The first one removed the majority of the fibroid, and then the second look still two small submucosal myoma remain. Again, you can see the tortuous, the blood vessel on the surface of the myoma. So you can see why the patient easy to get bleeding. Again, the second look and remove it. So finally, almost clean. And the patient had 2 pregnancies and had 2 babies. And this is more complicated. You can see the tortuous, vigorous vessels, continuous bleeding. And this size around 3 centimeters during the laparoscopic examination. So again, I did the remove this submucosal myoma by laparoscopic approach. So you can see here, use electrocautery. This is a flexible laparoscopic removal of the, so you can cut the majority of the submucous myoma and remain small portion of the myoma in the intramural portion. Quite big, yeah. Okay. I'm sorry, well, what's happened? Wait, I cannot see. Sorry. Okay. So the second look, you can see almost all the blood vessels are shrink, and then because we disconnect the blood supply, it turned out to be smaller and with pale and in appearance. And then you can remove easily for the second look, and after 2 or 3 months, you see almost clean, and the submucosal myoma subside. And again, for those patients with intramural myoma, this is another second case. This is in a 33-year-old woman, and she had a spontaneous pregnancy 3 months after myomectomy. So you can see this is a big 3 centimeter by 7 centimeter in size. So multiple myoma, and then we can do a myomectomy, and she conceived spontaneous 3 months after the surgery. So this is another intramural myoma, a 30-year-old lady, primary for 3 years, multiple intramural myoma, and she failed IVF once. And again, you can see this is a big anterior myoma, posterior, and also this inside this fibroid, there are some cystic degeneration. So you can see after remove, you can open the myomectomy degeneration here. And after the surgery, I think the surgery is in February, okay? So 4 months later, she conceived. We can see last week, she came back with early gestational sac in ultrasound examination. So the management strategy for uterine fibroid, we have surgical approaches or non-surgical alternatives, such as uterine artery embolization or HIFU or MR guide focused surgery. And also we have different management by medical treatment. You can use transamin or IUD, progestin coated IUD, or selective progesterone receptor modulator, IU486, or GnRH agonist, antagonist. The majority of the advantages try to reduce heavy menstrual bleeding or shrink the fibroid or correct the anemia. But still, there are some disadvantages. For example, when you use the progesterone receptor modulator, sometimes, according to Jack Donay's publication, associated with some endometrial changes, so-called PACES. So still it's very cautious. And also when you use the agonist or antagonist, still the patient can develop the bone marrow density loss. So, and again, now they have some oral GnRH antagonists available now. But be aware, in the recent publication from New England Journal of Medicine, when we do the uterine artery embolization versus myomectomy, again, the myomectomy had a better fibroid-related quality of life. So you can see here, this myomectomy, this uterine artery embolization, and this is quality of life measurement, the questionnaire after 2 years, the higher, the better quality of life. So again, you can see patient receive myomectomy, the satisfaction rate is much better, it's better than uterine artery embolization. Now, I will switch to the adenomyosis and the ART. You can see here in patient with adenomyosis, this is the foci in the tissue. You can see there are longevity genes highly expressed, which is 62. So this is why patient with the adenomyosis is not easy to be cured, because the gene, they can survive longer. And then what is the mechanism that impair the fertility potential in patients with adenomyosis? Because local increase the estrogen, and this is increased estrogen can increase the peristalsis of the adenomyosis, and also induction of the tissue injury and repair, so-called TIAR, in the junction zone. And this, at the same time, the adenomyosis also, they can down-regulation of those implantation genes, such as FOXO1A or HASTA10 integrin, as well as the leaf protein. And besides, they also increase the macrophage MCP1, natural killer cell, and the CD60. All these will impair the implantation. And then we try to examine our patient. You can see here, this is the endometrial gland with hemorrhagic opening. You can see during the hysteroscopy, you can see the hemorrhage spot opening on the surface of the endometrium of adenomyosis. This is why those patients are not easy to get pregnant. It's continuous bleeding and bleeding. So the embryo is not easy to implant. So you have to cure this pathology. And the image starting of adenomyosis, as you know, the MRI is much better than traditional vaginal ultrasound because the area under curve is 0.9 in MRI compared with the 0.8 in transvaginal ultrasound. So the correct diagnosis was easy to obtain and more often with MRI. So you can see the MRI is very easy to appreciate this widespread thickening of the junction zone with numerous high signal foci and a loss of the definition in the endometrial margin. So it's more easy to be diagnosed by MRI rather than transvaginal ultrasound. And there's numerous publications try to explain, especially for patients with IVF in patients with adenomyosis, they are decreased the ongoing pregnancy rate. So you can see here, there are 3 publications, and this blue bar is adenomyosis. Okay, so equally, the ongoing pregnancy rate is suppressed compared with control. See the control will be much higher pregnancy rate compared with adenomyosis. So we must do something for those patients. However, when patients receive downregulation with GnRH or so-called pretreatment with prolonged GnRH treatment in these 2 publications, you can see the pregnancy rate is almost identical with the control group. So that's very obvious and clear. GnRH pretreatment may do some beneficial effect to those patients with adenomyosis for IVF. So we have one patient, she's 40 years old, secondary infertility for 10 years. She had anemia because of the big adenomyosis and severe with antiphospholipid syndrome because a bunch of antibodies. And her CA-125 is very high, about 576. However, she reduced the CA-125 level to 34 after 2 months of the GnRH pretreatment. So you can see here, this before GnRH, the size is very big. You can see the size of uterus is 9.9, very big. However, after two months treatment, reduced the size to 7/6. So you can see the tremendous effect of GnRH. And then we have some pilot study. We collect 10 patients, okay, 10 patients, age range from 39 to 40. And you can see the CA-125 level before GnRH very high, 100, 200. After GnRH almost return normal range, you can see about 31, 20 again. And in addition, when you look at the uterine size, before GnRH is very big, and after GnRH they reduce 63%, 29%, 70%. So you can see the tremendous reduction of the uterine size after GnRH, 1 or 2 months treatment, and 4 of them get pregnant, conceived. Then we do the following study. We collect 36 patients, received ultra-long treatment. That means 1 or 2 months GnRH, the other 7 with antagonist treatment. The only difference is the outcome. You can see for ultra-long group, you can see the clinical pregnancy about 36%, but implantation and ongoing also ongoing pregnancy rate about 28%. When you look at the antagonist group, almost 0 pregnancies. And then because I think age is very essential contributing factors to pregnancy rate. So again, we divide those 36 patients, 2 groups, age under 38 and age over 38. So with 16 is the younger patient, 20 is a little bit old patient. The only difference is pregnancy rate. You can see when younger patient, you can have clinical pregnancy of 5-6%, implantation 25%, ongoing pregnancy 50% compared with the age over 38. So age is important. for adenomyosis. And what is the potential mechanism of the direct effect of GnRH on adenomyosis? 5 reasons. Number 1 is the GnRH, they can reduce tumor size by down-regulation of the TGF-beta. Also, they inhibit inflammation by diminished IL-1 and the induction of the apoptosis by suppression of the BCL2 or increase the BAX gene. The number 4 is oxidative stress. When they receive the GnRH treatment, oxidative stress much less because the NO also diminished. Finally, the angiogenesis also diminished because all the VEGF are totally suppressed by this treatment. And again, a couple of years ago, we published a paper in Fertility Sterility. For those patients with uterine myoma, also the GnRH agonist prolonged treatment also, they can suppress all those genes such as MAP kinase, VEGF, or some inflammatory gene, proliferative gene, etc. So the mechanism of the GnRH for the uterine myoma is very similar to adenomyosis. And then you can see the for long-term pituitary downregulation before the frozen embryo transfer for IVF also could improve the pregnancy outcome in women with adenomyosis. So you can see downregulation first, and then frozen embryo transfer. You can appreciate the implantation rate is much better than control. Clinical pregnancy 51, 22 for control, and ongoing also about 49%. So downregulation, very, very important. And again, some meta-analysis, you can see a lot of publications showing the clinical pregnancy rate is much, much compromised in adenomyosis compared with control. You can see the clinical pregnancy only 0.2. And besides, they increase the miscarriage rate. You can see here in patients with adenomyosis, the miscarriage rate is around 2 times higher. You can see 2 times higher in patients with adenomyosis compared with the control. So again, for those patients, if the CA-125 is big and it is high and big adenomyosis, sometimes radical resection of adenomyoma tissue is necessary. And Dr. Osuda, they already developed a so-called triple flap methods. The first one is cut the uterus, entering the uterine cavity, and remove the both sides adenomyotic tissue, and carefully, meticulously repair the endometrium, and then triple flap method to repair the uterine myometrium. And most important is after the surgery, see, we usually do a second look hysteroscopy. You can see still some residual adenomyosis here. So you still need some surgery or need a GnRH following treatment to remove, and then the patient can have the pregnancies. And so that is the successful pregnancy after conservative surgery for morbid or malignant adenomyosis. So you can see after the surgery, there are variable pregnancy outcome from 16% to 6%. But however, there's a large group from Japan. You can see 100 patients, and pregnancy rate can reaching 41% if age under 40. Still, age is very important. However, only 3% if age over 40. So again, you can see the importance of the age and the probably size and the pre-treatment or not with GnRH or not. So for those patients with poor responders, sometimes we consider this downregulation, the side effect. So again, we can use the segmental IVF approach, or adenomyomectomy. So depend on the patient's situation, depend on whether the patient is normal responder or poor responder. So that's the final diagram for IVF in adenomyosis. If the patient or patients should receive GnRH downregulation, if the GnRH return to normal, we can do IVF for oocyte retrieval and do embryo transfer fresh. However, for severe adenomyosis, for poor responders, then we choose segmental IVF. That means we do the ovarian stimulation and the egg retrieval first, and then downregulation of the patient with the GnRH until the CA-125 less than 35, then we do frozen embryo transfer. However, if the CA-125 is still big and the size is still more than 10 centimeters, then we, in between, we select adenomyomectomy. And then downregulation and the frozen embryo transfer. Okay, so that's my last slide. I will thank my collaboration across the Taiwan, the whole island, with my previous physician assistant fellow and my lab and so on. Thank you very much for your attention.
Thank you, Professor Chii-Ruey, for an excellent lecture as usual. So we'd like to open the floor for questions. Please type your questions in the chat box. And let me fire the first question, Professor Chii-Ruey. You've discussed hysteroscopy prior to natural conception, AI, or even frozen embryo transfer. How do you prevent intrauterine adhesions from occurring after hysteroscopic procedure?
Usually, because only 10% of the infertile patients have some pathology, so 90% is normal. So usually I do routine office hysteroscope with 3 millimeters fibroscope to see without anesthesia. So 3 minutes, you can examine the whole cavity. So 90% will be okay, but 10% with some uterine pathology. So usually we need to do the septum resection or polyp removal or the submucosal myoma removal. You can use the yellow barrier, the gel to prevent adhesion. But the most important is technique. If you're meticulous, careful technique, usually there's no adhesion. Just I show you in my slide. Usually no. But if you are very concerned for adhesion, you can use the gel yellow barrier to prevent adhesion.
Okay, thank you. We have a question here from Mr. Qatar Iraqi Husseini. What is the posology of GnRH? I presume he was referring to how much would you give for a segmental IVF or in contrast or an ultra long protocol that will allow you to improve your pregnancy rate?
Very good questions. Okay. Normally, the patient receive 2 months, that's more than enough. Because after even the patient CA-125 is very big, more than 200, 300, after 2 shots, 2 months, usually can see the downregulation of CA-125 less than 35. So there are 2 criteria. One, if the patient, the uterine size reduced to 30 to 40 to 60%, then you can proceed IVF, or the CA-125 can goes down to 35, you can go for IVF. If the patient, the uterine size, the adenoma is still very big, more than 10 centimeters in diameter, second, CA-125 cannot go down to 35, then we consider adenomyomectomy. So adenomyomectomy usually is the last option. The first option is try to medical treatment, GnRH pretreatment, and 90% of patients no more than 2 months. Yeah, believe me, they will shrink, and you see the size shrink about 60%. So easy to do the IVF. or use IUI or do the natural conception.
Okay, thank you. What about when do you start HRT for segmental IVF? After 2 months, we don't wait for period because the period does not arrive after 2 months of GnRH.
Yes, yes. After 2 months, you see normal CA125, the uterine size shrink to about 6 centimeters in diameter. Then you can apply the HRT for H84, and then usually the pregnancy rate is very high.
That's good. So we have another question from Olaric. Hello, Olaric. Do we need GnRH agonist after adenomyomectomy? Will that be, Olaric, will that be a
Please, yes.
Agonist for IVF or for segmental? How would that be?
Okay. After adenomyomectomy, usually I do routine hysteroscope to see if there's any adhesion, or because sometimes we go into the uterine cavity, so you can create some adhesion or some residual. No, I just see there's some endometrial adenomyosis openings in the endometrium. So the subsequently GnRH for about 1 or 2 months is necessary for adenomyomectomy. The second reason, reason is usually after 3 months, the uterine enough time to heal. So please wait until 3 months after surgery to any kind of IUI or to embryo transfer, etc. 3 months is very important.